Introduce our first speaker, which is going to be Dr. Lisa Kokontis. Dr. Kokontis is a neurologist at the Neuroscience group in Neenah, where she specializes in neurological. And movement disorders such as Parkinson's disease. We're extremely proud that she's a member of WPA's Medical Advisory Committee. Dr. Kokontis.
Hi, good morning. So, for all of you who are coming in, thank you again for tuning in today. It's a wonderful thing of technology. Sometimes we curse it, but this is a blessing today, I think. This talk was given, I think, last year or the year before, and Jeremy asked me to bring it back today. I think there were things that a lot of people learned about that they were struggling with and really, in fact, didn't know it was a part of their Parkinson's disease. And so we're going to talk about the non-motor symptoms of Parkinson's disease today. And go ahead and go to the next slide. So we're all familiar with the motor symptoms of Parkinson's disease. Why do we call it motor? Motor in medical terminology means movement, essentially. And so the movement symptoms of Parkinson's you're all familiar with is a tremor, being slowing down, tightness or stiffness in the muscles, and trouble with walking and maintaining your balance. You can go ahead. Next slide. But there are many, many non-motor symptoms. These are the ones that I collected, but they're more than this. These are the ones that seem to be pretty disabling, and in my opinion, just as important to recognize these and then treat these things, just like the motor symptoms. We're going to go back and look at all these things individually, so you don't have to worry. We'll hit each of those topics. Go ahead, next one. So people who with Parkinson's, well, really anyone these days complains of fatigue, but especially if you have Parkinson's disease, it's even more severe. There's probably a lot of reasons for this. Poor sleep, we'll get into that a little bit, what contributes to that. Side effects of a lot of the medications we treat people with can also contribute to sleepiness and fatigue. And there also is thought that just simply having Parkinson's disease itself is a contributor to the fatigue. Next slide. So what contributes to poor sleep? Here's just a few of the things, but these are the most common. REM behavior sleep disorder, restless legs, insomnia. And the last thing is you get up multiple times during the night to empty your bladder. And that, of course, in medicine, everything has a name to that symptom, and that's called nocturia. Next slide. REM behavior sleep disorder is very common in people who have Parkinsonian syndrome, not just any run-of-the-mill Parkinson's disease, but also other Parkinsonian dementia. And normally, when we sleep and we dream, that is a stage of sleep called REM, rapid eye movement sleep. And normally in that stage of sleep, our brains paralyze our muscles, so we don't get into trouble acting out our dreams, running, kicking, all of that. But in people with Parkinson's disease or Parkinsonism, their muscles don't become paralyzed, and they can move and act out their dreams. And they can even hurt their bed partner because the movements are just as strong of punch and kicks as they would be as if they were awake. So this can even lead to injury in the person who has these dreams. So you can imagine, usually most people REM 3 to 4 times at a sleep, and if you're acting out your dreams 3 to 4 times a night and then waking yourself up, that's certainly a sleep disruptor. Next slide, please. And so how do we deal with that? The simplest thing is over-the-counter melatonin. That's something you can find in the vitamin aisle. It comes in various strengths. The brand matters for the supplements. Not all the supplements are reputable. The brand that I tell people to get is Nature Made brand. It's usually fairly consistent in its potency, and they have differing pill sizes, so it's pretty easy to use. And that, settles that down quite nicely. Usually you have to go up into a bigger dose, I would say anywhere from 9 to 10 milligrams at night, and it can be increased up to 16 milligrams. It's been shown to be safe. So not only does melatonin help you, suppress that behavior, it also induces a nice sleep. And if you use it on a more regular basis or nightly basis, it's certainly safe to do that. And over time, it can consolidate your sleep so you're not waking up all the time. So it's kind of, if I see someone, really virtually anyone, who is telling me they're having trouble sleeping, that's the first drug that I reach for. It's safe, it's effective if you get the appropriate brand. If that doesn't work for you or you don't tolerate that, there's a prescription called clonazepam, and that works well too. It has some side effects. It can increase imbalance or increase confusion. So if we have to use that, it'd be with a low dose with the understanding to stop it if those things happen. And lastly, you want to make sure that the person's safe. If they do fall out of bed, you don't want them to injure themselves, particularly if they're on blood thinning medicine. Sometimes we put the mattress on the floor or lower the bed so that there's not a big height between the bed and the floor. Some people get up out of bed and walk around, and you want to make sure that they don't leave the apartment or the house. So you lock the doors and lock the windows just to keep people safe. Next slide. And the next thing is restless legs that can bother your sleep. And it's very common in people who have Parkinson's disease. It comes in all sorts of flavors or whatever. The sensation that people describe can be very different. People, when you read in the textbook, they'll say they have tingling or numbness or a sensory symptom, but it can be even a tightness in the legs or a feeling of drawing of the muscles or cramping. It's just, I would say, don't pen yourself into a certain sensation because the doctor may miss it. But if you just say, I have an unpleasant sensation in my legs that keeps me from sleeping, then we're more likely to pick up on that diagnosis for you. The other thing with restless legs that's unique is most other pain in the legs gets worse when you walk around. Think about osteoarthritis or other joint pain or even back pain with sciatica. It certainly can worsen as you walk, but with restless legs, it improves. And in fact, it goes away if you're walking around. And that's an important tip to tell your provider, because then that really pretty much clinches the diagnosis. The other thing is with restless legs that's very unique is it seems to be worse at night or only at night. I don't know why that nocturnal predominance occurs, but that's usually how it starts. It usually starts to creep in sometime after supper time. You have a little bit of trouble watching television, sitting down without moving your legs. And then it certainly can prevent you from falling asleep if you can't get comfortable. Next slide, please. So what do you do? It's unlike REM behavior sleep disorder, restless legs is common in the general population. It doesn't necessarily predict or mean that you're going to develop Parkinson's. And in fact, I have a number of people who don't have Parkinson's disease, and this seems to rev up in certain times of your lifetime. And for one of them is pregnancy. And pregnant women pretty much really want to avoid medicine. So what we have them do is really exercise, even before bedtime. We'll give them a routine where they can do deep knee bends, maybe be on the treadmill for 10 minutes. I have a fellow with Parkinson's disease that has a stationary bike that he uses before bedtime. And that can certainly quell the symptoms for several minutes. And once you're asleep, it goes away. In fact, the Parkinson's medications, things like pramipexole or ropinirole, or even levodopa, carbidopa-levodopa, can quell the symptoms. And they do a great job of it until you develop tolerance to it for this particular symptom. And then you have to keep increasing the dose to quell the symptoms. We call that augmentation of the medication. And it really isn't a good way to treat this, because you're going to be increasing your dopamine for the wrong reasons, really. We want to use dopamine to help you move, not to quell restless legs, because you can become toxic then if you use that dose that's needed to quell the restless legs. So fortunately, there's another medication called gabapentin that I like to use. And the good thing is it's in a low dose. It usually will take effect immediately, and you can adjust the dose to what the person needs. There's a cousin to gabapentin called pregabalin, similar success with it. And again, here comes clonazepam. That's another drug we use to treat REM behavior. Well, it does help also quell restless legs. But again, same thing. It can have side effects to it. This is one drug that I have used in if everything else fails. Low dose, low potency narcotics, even codeine can help. And in that situation, I feel that getting a good night's sleep or not getting a good night's sleep is more risky to someone's outlook and outcome than the side effects of the narcotic. And we watch them very carefully to make sure there's no issues with confusion or balance and gait. Next slide, please. Then there's this insomnia. Insomnia can mean different things to different people. You can have early insomnia, which means you just don't fall asleep when you want to go to sleep. And then there's terminal insomnia, which means you fall asleep, but you wake up much earlier than you want to, and you can't fall back asleep. It's pretty common in Parkinson's disease, and there can be many reasons for it. It can be due to medications effects. So one that I listed is amantadine, which is an excellent drug to treat some of the symptoms of Parkinson's. But as with every drug, there can be side effects. And for amantadine, it can be that it makes you more awake than you should be before bed. So typically, we try to dose amantadine early in the day and not before bedtime. So we want to treat the underlying factors, limit naps. It's good to lay down for a nap, but no more than an hour a day. Otherwise, you won't sleep at night. You want to stop the offending medications that can be causing wakefulness, such as caffeine. Caffeine isn't a medication, but it's a drug. You want to make sure you're not dosing with caffeine, several hours before sleep time. Depression can give you insomnia. We haven't talked about that, but that certainly can be a symptom of insomnia, and treating depression is very important, as we'll find out later. Anxiety, OCD, obsessive compulsive disorder. Some people have developed that or have it in addition to Parkinson's disease. And just not being able to turn your thoughts off or ruminating about a certain thing, and you can't get off of that right before bedtime. We need to kind of disrupt those thought processes and there's strategies to do that. Typically, a nice restful activity before bed. Try not to read about the problem or whatever it is that's something that the person is ruminating about. Try to break that thought pattern up. Now, the other thing is pain. If you're in pain, we need to treat the pain. When I see people in the office, I ask them, how are you doing? Of course, any falling? How are you sleeping? Are you in any pain? Those three things are really important to their well-being. And if you're in pain, let's figure out what it is, why it's there, and fix it so that you sleep well, and then the next day you move well, because that's important in Parkinson's. So, we can give you melatonin. Like I said, that really does help. It's a nice sleep agent. Again, Nature Made brand. If you could find that, that's the one to get. Sometimes I give people, if they're also depressed, I will choose for them a sedating antidepressant, and they'll take that before bedtime, and that works quite nicely. And then exercise. Exercise wears you out. It wears you out mentally, physically. So if you can plan for exercise every day or most days of the week, maybe not before bedtime unless you have restless legs, but if you exercise, a regular program will help combat the insomnia. Next slide, please. So wrapping, fatigue up. You should, again, look for an underlying cause and treat it. And in my opinion, if you don't treat fatigue, your Parkinson's disease won't be well treated. There's a lot of conditions as we go forward with this talk that if we leave untreated, it interferes with your symptoms of Parkinson's disease. So fatigue is one of those symptoms. We need to fix it, and so you can move on, treat your Parkinson's. So we try to look for an underlying cause and treat it. So poor sleep, insomnia. Are you snoring? Do you have obstructive sleep apnea? Those are easy things to pretty much ask about and then study and then treat. Fatigue can also be caused by what we call orthostatic hypotension. That means when you are upright, either sitting or standing, your blood pressure plummets. And that can make you feel fatigued. It can also have other symptoms accompanying that, but fatigue is one of them. And so that's an easy thing to fix as well. We're going to talk about that more. If we can lower the drugs dosages or switch them to an extend-release formulation, that also helps the sedating side effects. And sometimes I fixed it. We've fixed all these little things, and you're still tired. Well, maybe that's the fatigue of Parkinson's. And sometimes what we'll do is consider a stimulant, maybe an amphetamine or a non-amphetamine type of stimulant. Next slide. You can also use medication side effects to treat fatigue. Remember, amantadine, you don't want to take it before bed because it can keep you awake, but maybe you want to take it during the day. And fluoxetine is an antidepressant medication that also is activating, and that's something if you have depression and insomnia, you could use fluoxetine in the morning so that you can be more active in the morning and maybe sleep better at night. These other medications can have side effects that affect your sleep. These next three, donepezil, rivastigmine, and galantamine, if the companies all say you should take at least the donepezil at nighttime, and I think it's because some people get nauseated with it when you first dose with it, and they want you to sleep through the side effect. But I found that it also causes very vivid dreams, and they can be nightmares. And then that wakes you up, and then it's hard to get back to sleep after something like that. So if that is happening, we'll switch the dosing to the morning instead of at night. That's a simple trick. Rivastigmine and galantamine are actually dosed twice a day, so it's a little tricky there. but there's ways around that. Rivastigmine can be switched over to a patch formulation, so it's a steady dose all day long. Dopaminergic medications, which a doctor gives you to treat your motor symptoms, are sedating. And then there's that temptation to nap once you've dosed. So you have to be really careful, pretty regulated, that if you do nap during the day, that you wake up, not nap the night or afternoon away, but set your alarm even for an hour so that you just make sure you wake up after an hour of nap time. Next slide. So the next thing people have, it's very common, people with Parkinson's disease become constipated. And this is a symptom that people, when they look back on their health history, they had for many, many years, even before the motor symptoms started. And we know that when we look at the nerves in the gut, they also have the same pathology with Lewy bodies. And that's what slows the intestinal transit time down, is those nerves aren't working well, just like the nerves in the brain. Next slide. So constipation is really a struggle for many people. In fact, I have a constipation protocol that I have written up and type up for people and hand it out, because it's very, very common. Even for non-Parkinson's patients, people deal with constipation with other medical conditions. So we want to make sure there's some simple things to do that you can do without prescriptions. It's just add some fiber to your diet. There's a power pudding that you can put together. I think that WPA has a little pamphlet with the recipe on the power pudding, and that includes applesauce, bran, and prune juice. And you can keep that in your refrigerator, but every day take a couple of tablespoons of that. It's quite tasty, actually. And that gives you, it's packed with bran and fiber. The next thing we don't do a very good job in is in making sure you're drinking enough fluids. Especially people who aren't moving a whole lot, they may not have the thirst that they to make them want to drink. And so one of the tricks that I tell caregivers is to make sure that their spouse can get some salty snacks, and that might encourage them to drink more. Potato chips, pickles, whatever is salty that they can handle and manage is kind of a nice trick. Same thing with sweet things. Maybe they have a sweet tooth. If something's really sweet, you kind of want milk or some other fluid, maybe water, to wash it down with, and that can make sure that they have enough fluid in them. But you really do need to encourage someone to drink. And what is enough fluid? I'd say 96 ounces a day is enough. If it's a really hot day, you're outside and you're sweating, probably you want to go with 128 ounces a day. That's about 2 liters of fluid. The other thing you need to do to encourage your bowels to move is to exercise, not be sitting in one place, but to get up and move around. And exercise, you don't have to go out and run a marathon, just go and take walks. And it doesn't have to be very far. You can divide your exercise into 10-minute bouts of time per day so that you get it all in. And that it really does help improve the constipation. Next slide, please. So there's constipation medications, obviously. The first 3 are available over the counter. Again, bulking agents or fiber agents. You can get that through your diet, or you can find them over the counter. And then there's some laxatives that you can use, Miralax, Citracel, Metamucil. And then there's stimulant laxatives, and what they do is they actually stimulate the muscle of the bowel. They may give you a little cramping. There are prescription medications, the last class there. And if all those above there fail you, you can ask your doctor for maybe a prescription, and those work pretty well. So the point of this is you don't have to suffer with this, and if you're immobilized by this, that's terrible. We need to fix it and get you moving again. Next slide, please. I think on Friday, you'll hear a talk by Julie Bobholtz about the mood changes in Parkinson's. So she's going to go into this more, but certainly people with Parkinson's can become depressed, or it's either maybe due to the circumstances, or we even think there could be, again, an underlying piece of the Parkinson's pathology is affecting mood. It's very common. 35% of people have depression. And it can manifest in many ways: disinterested in usual activities, disrupted sleep, either not enough or too much, disrupted or a change in your appetite, either overeating or not enough eating. Feelings of hopelessness and guilt can occur, and maybe those are hard to tease out if your spouse or person you're taking care of isn't, open about how they feel. There is a lot of, there's various depression scales or inventories that your family doctor can give that can give an idea of this is going on. In fact, we do one in the clinic here, and so if that's a concern, that's something that we can tease apart a little bit more, and we should, again, get after that and treat that. People can become irritable, change in personality. They can have something called apathy. They don't want to do anything. They just prefer to sit all day, not doing anything. People who are undergoing consideration for deep brain stimulation, we truly do screen for this because the deep brain stimulation may worsen depression, and we want to make sure we treat that before subjecting them to something that's going to make it worse or potentially make it worse. Next slide, please. So how do we treat depression? The simple things first: improve sleep, exercise. Sometimes it just helps to talk to someone. If your depression is related to the situation that you're in, it may not even be Parkinson's disease, but it could be family discord or spousal discord. And sometimes just finding a strategy to manage that stress is enough to lift your depression. And if those things fail, medications can be prescribed. Next slide. And these are the classes of drugs that we can use. There's many different drugs in each of those classes. And the point of this slide is that your doctor can choose the drug for you, what's going to work best for you, with additional information on sleep, appetite, if you're anxious. Those are the three things that I try to ask, because some of these are sedating, some of these medications are activating, some of them make you lose weight, and some of them make you gain weight. So you want to choose the appropriate drug for that person's depression and their medical history. Next slide, please. Next is dementia. Everyone's fearful of that. But it's not everyone who has Parkinson's will develop dementia. It's about 30 to 40%. The older you are, the more severe your symptoms of Parkinson's, and the longer you've had the disease or risk factors. And in one study, the mean duration of Parkinson's disease was 14 years before they developed dementia. Next slide, please. So the features of dementia are different than Alzheimer's disease. And in Alzheimer's disease, the most prominent features are memory loss, short-term memory loss, and word-finding difficulties are the most common initial symptoms. So that type of person would be more repetitive. They might say the same statement in the same conversation more than once. They might lose things because they can't remember where they put them. And they have word-finding difficulties and are really trying to struggle to keep their train of thought. But people who have a Parkinsonian dementia will have a different type of struggle. And typically it's more with planning and judgment and attention. So it's typically, for a scenario, maybe, oh, mom used to be able to, we used to go to mom and dad's house for Thanksgiving, and she would put it all on. We didn't help with anything, no shopping. She did all the cooking and cleaning and the whole 9 yards. And afterwards, she cleaned up after us. I don't know. That sounds terrible to me, but that's something that people notice about their parents. But if you have a difficulty with Parkinson's dementia, trying to put together a meal plan, then shopping for it, and then cooking it, and then cleaning, it's quite overwhelming. So those are the things to kind of be checking out. Is this a change in the person's functioning and on more complex tasks rather than memory tasks? People with Parkinson's disease, I see this every day, can have vision and space distortion. So some of the things you may see is the person trying to sit in a chair, for instance. They're coming in from another room and they want to sit in the chair, and they land on the arm of the chair. Why is that? Well, they don't see the space like they used to. There are a lot of things that you can do for that. One of the things that you want to probably do is, for instance, if you have chairs that have the same color arms as the seat, you can bring out the color of the arms more so that they can see that's the arm and that's the seat. Upholstered chairs, for instance. You can bring out the color of the arms with brightly colored duct tape, so you just stretch it out, or some other cloth that you stretch out on the arm so they can see the difference. I need to be between these two brightly colored pink arms, and that's where I sit. Same thing with the commode or the toilet. They might sit on, half of the toilet for the same reason. They don't see their vision and space relationships are not normal. There also is some difficulties in recognizing faces. So they may understand or know a familiar voice, but it's hard for them to know who that person is based on what they look like. The vision and space distortion is a problem if they're driving. If you can imagine, how do you park the car if you can't see between the lines, or for parallel parking would be a disaster. How do you turn not to go up over the curb? Could you hit someone? So if you're starting to see those things, that person should not be driving. Next slide, please. There are some neuropsychiatric symptoms of Parkinson's dementia that can be prominent even early on. That's another distinguishing piece different than Alzheimer's. Alzheimer's, you will not see the neuropsychiatric symptoms until late. But for Parkinson's, they may be there earlier. And those are usually hallucinations and delusions. And hallucinations are seeing, hearing, touching, smelling things that aren't really there. And the hallucinations can be just either really poorly visualized or just a sense of something's out here in my periphery, and then when I look there, they're gone. Or they can be formed, such as seeing whole people, children, insects, animals. They truly see that, and they always, will ask you, do you see those 4 people at that table? Do you recognize them? And you don't see anything. That's a hallucination. Delusions are a thought or a belief that's not true. So you're not seeing things or hearing things, but it's a belief in that you're thinking something is happening, but it's really not true. And these are often delusions of spousal infidelity. So accusing you of having affairs, which truly that's not going on, but try to tell that person otherwise is very difficult. or delusions of persecution. Other people are out to get me. I'm not safe. And those are hard to deal with, especially if you're the spouse trying to take care of them and you have to go and do things, shop, cook, clean, and they may not be right there with you and they think you're having an affair. That's difficult. Next slide, please. So for dementia treatment, we don't have a cure yet, but smart people are working on this. We do cross over and use some of those drugs that we use for Alzheimer's dementia, and particularly acetylcholinesterase inhibitors. They do seem to have, in my opinion, a significant symptomatic benefit, particularly for hallucinations and the delusions. And it's important to get those started for it if that's what's going on. That's a first class of drug I would try because it can help prevent other maybe more drugs down the road that are needed with more side effects. The other thing to do is try to dial back on some of the medications that you're on to treat your Parkinson's. You know, dopamine can increase confusion. That's one of its side effects. It can drive hallucinations. And if there is an opportunity to pull down some of those medication dosages, that should be done as well. Next slide. So that's exactly what we do. For psychosis treatment, we lower or taper drugs as long as it doesn't interfere with worsening your motor symptoms. And sometimes as you get older, you don't need as much because your metabolism slows down or your activity slows down. And so I find myself often lowering the dose without any compromise in your motor function. We can give antipsychotics. We use a special class called the atypicals that are safer, that won't cause trouble with your Parkinson's motor symptoms. There's a drug, pimavanserin, that was developed a couple of years ago, I believe now, and that's also useful if the other two classes or the other two strategies aren't helping. And of course, you want to avoid any other medications like Benadryl type of drugs. Those are also called anticholinergic drugs. And I don't expect you to know if a drug has anticholinergic properties, but your doctor will. So if you're prone to having confusion with medications, that's a good conversation to have with your doctor when a new drug is about to start. Will this make me confused? Just so that you know exactly what to look for. Next slide. Drooling. Who knew that this is a side effect of Parkinson's or a symptom of Parkinson's? But it's, your swallowing slows down just like your other muscles. So it's just due to slowed swallowing. It's not due to increased saliva production. And just chewing gum, hard candy will encourage you to swallow. And that's the first strategy to use. And then there are drugs you can take. There is something called glycopyrrolate, which is safe. It's a 50-50 shot on whether it works or not. You have to kind of push the dose to tolerability and effect, but it can help. And then there are other drugs. They're also called anticholinergics, and one of their side effects is drying you up. And that's how they work, is just to dry up the saliva, not necessarily stimulate swallow. But again, the anticholinergics, like the previous slide, can cause increased confusion. So you have to be careful with that. The last thing I forgot to mention on this is you can Botox the salivary glands. Believe it or not, your spit glands have little muscles that let that squeeze the gland to spit out, for lack of a better word, the saliva. And if you can weaken the muscle in the gland, that will help reduce the amount of saliva that's released into the mouth. Next slide. Orthostatic hypotension, I would say, once can give you, if you treat this, has the highest impact on quality of life because people feel sick when this happens. If you imagine a hot day, it's hot outside, and you come out and it's hot and humid, I don't know about you, but I feel sick. It makes me nauseated, the heat. Similarly, when your blood pressure is too low, that's how you feel. You feel sick and nauseated, you're fatigued, you want to lay down or sit down. So what orthostatic hypotension is your blood pressure drops to a significant degree. You might start out at 120 when you're sitting, but when you stand up, your blood pressure plummets. It can go as low as 60 or 50 even. When it falls that low, you oftentimes will lose consciousness or completely pass out. But if it's not that low, maybe it's 60 or 70, you just don't feel well. You have no motivation. You don't have any energy. You're fatigued all the time. Next slide. Again, to treat this, you want to make sure you have a lot of fluid in the tank. Increase your fluid because a lot of your blood volume depends on what you drink. Again, you're trying to increase your blood pressure if you think of it that way. And if you don't have any volume in the tank, you don't have any blood pressure. You can try to change position slowly. So go from sit to stand or laying flat to sitting and taking time, letting your head clear of the butterflies and the birds, and then stand up and same thing, let your head clear and then move. But sometimes this orthostatic hypotension occurs after several minutes of standing up and you feel pretty good and then suddenly it goes down. So you have to learn to recognize your symptoms. And if you feel that, you sit down right away so you don't pass out. So you want to change position slowly. Salt your food, despite what your cardiologist says. If your blood pressure is too low, you need to increase it. And salt does that by increasing the water withdrawal from the soft tissues into the blood volume, blood vessels. And so if you salt your food, salt acts as a sponge to bring in fluid into the blood vessel wall, inside the blood vessel. If you don't like salt on your food, then eat salty snacks. Again, potato chips, popcorn, whatever is salty that you like, pretzels, whatever. Eat those. Those are a good source of salt. Salt we also have available is salt capsules that give you a good amount of salt. You want to divide your calories into smaller meals. If you eat a big meal, your blood volume is shunted to your gut to digest. And so if you do that, big, huge meals 3 times a day, you're at risk for dropping your blood pressure after meals. Smaller snacks won't have that same effect, and that can reduce the risk of this occurring. If you wear tight stockings that will keep fluid from building up in your legs, you need it in your blood vessels. So compression stockings can help if you tend to have fluid in your legs. Ibuprofen is similar to salt. It kind of draws water in. Next slide.
Actually, we're going to jump in right now, Dr. Kokontis. I'm going to cut you short on your last 2 slides and ask you a couple questions that people have been submitting so we can kind of keep on schedule if that's okay. So first of all, thank you for presenting. I'm sure if you listen closely, you can hear the applause coming from all around the state. Appreciating you giving your time. 2 questions that have come up. One that just popped up a second or 2 ago. Does dopamine or increase of dopamine cause double vision or other eyesight issues? A lot of people have vision issues with Parkinson's and they're not sure if that's caused by dopamine or if there's another reason for that.
Yeah, that's a good question. I have to think about that. I guess one way to determine that, I think theoretically it sure could, and a way to test it is, does it occur at peak dose? So if you take your medicine and when your movement symptoms are the best, is that when you see double? Because if that's the case and that's a recurrent thing or recurrent finding, then yeah, for you it may be a side effect of the dopamine.
And then the other question that came up has been, does Parkinson's affect taste? Some people said that they oversalt their food so they can taste it. Others say nothing they do can really help with the taste. Is that a common issue with Parkinson's disease?
Yeah, it is. many years even before the motor symptoms occur, the smell nerves are also affected. Same maybe the same time that the constipation nerves are, your bowel nerves. And so people have a loss of smell. And they've even thought to use that symptom to screen people to see if they are going to develop Parkinson's disease down the road, and choose those patients that have that loss of smell and enroll them in clinical trials. So it certainly is common. And once you lose your sense of smell, your sense of taste is less robust as well.
Excellent.
And sure, it's very common. And salting your food can help enhance flavors. So I think that's a good idea to do that. You are eating, that's why people like sweet things, because it's easier to taste, and salty things, it's very easy to taste. And spicy things, they have some flavor. So you might over spice your meals just for that reason.
Perfect. Well, again, thank you so much for your time. I know this is not the way we normally do it, but I appreciate you joining us via video conference, providing some great resources for individuals. So thank you very much.
You're welcome.
For those